Chronic disease educator for WellMed. Very happy camper there. We take care of people's health before it breaks down. And so I'm going to give you some information today about a topic that I am very passionate about. I'm affected myself and my family, and over 40 years of nursing, I have certainly witnessed some of the things that I'm going to tell you about, and anything I can do to help, I'm willing to do. I'm joined today by one of our nurses. Gracie is stationed in Seguin, so you may see her if you happen to frequent a WellMed clinic. Thank you to the library for having us in today, and Tracy for sponsoring me. So we're going to talk about diabetes prevention. Very, very important topic because it's an epidemic, and we know what an epidemic is now. We know what a pandemic is. And I was reading a couple of days ago that by the year 2030, there will be 140 million people with prediabetes. That's a lot. So it's going to become pandemic. Hypoglycemia can be seen in prediabetes, and I'll explain what that's about in the slides. So in the way of housekeeping today, if you have personal electronics, it's very, very helpful if you'll turn those down so as not to interrupt the flow of the program. We ask for confidentiality in our meetings. People may share personal information. We want to keep that here and not have it go out. I can hear better if just one person is talking at a time, and I'll give you a chance to talk, and then please ask questions. I get paid by the questions, so ask questions if you don't understand something or we need to go over things. So we're going to look at what diabetes is in order to know what prediabetes is. They're kind of the same and kind of not. And we'll cover those when we look at the organs involved in diabetes. Who's affected by this disease and how we diagnose it. Why do we need to be concerned about it? And then we'll look at tips for prevention. So as you can see on this slide, we have hours after a meal, 2 hours, 4 hours, 5 hours, 8 hours, and then we have blood sugar levels. And when you do not have diabetes, after you eat, you go to the table hungry in the 90s, ready to eat, and when you eat, the blood sugar does not go over 139 milligrams. That's the weight of the sugar in your blood system. But when you have prediabetes, you're going to go a little higher, and then it's going to come back down. When you have diabetes, you eat a meal, and that blood sugar can go way, way up into the 200s and 300s. So you see quite a difference in the numbers here, and this really matters because our bodies keep things within a certain range. That range is a steady state, and the medical term for it is homeostasis. And our bodies keep very tight control of sugar because sugar is like a little razor blade. It's like a little crystal in our blood system, and it cuts you, and it damages blood vessels and nerves. Prediabetes is going to be when the blood sugar is mildly out of range, not quite to the point that we see in diabetes. It is a separate state, but some of the underlying problems and some of the underlying effects of having prediabetes are exactly the same as when you have diabetes, so we do want to be concerned. So at present, 96 million people have diabetes, and of that 96 million, 8 in 10 do not know that they have it. And so to your question, sir, in the pre-diabetes state, our body is revved up trying to get that blood sugar down. And sometimes all of that insulin that has built up will break through, and you can get really, really hungry and get symptoms of diabetes. And we'll look at that a little bit more closely in a moment. I want to introduce today the National Diabetes Prevention Program. This was a study that was done in the early 2000s, and it was a 3-year study where we looked at people to discover whether or not diet and exercises versus medications would help to prevent diabetes, and we'll look at that in a moment. So why do we want to be concerned if prediabetes isn't yet diabetes? The main complication that we are concerned with diabetes is damage to the heart. And you see these, oops, go back. Okay, you see these blood vessels, I hit the wrong button, these vessels that sit right on top of the heart are called the coronary arteries. And cholesterol in our blood system has some proteins in it that hang out for a long time, called long residence time. And those proteins have more of an ability to damage the insides of these vessels. When we are born, fatty streaking already begins as soon as we start eating food. And so over years, these blood vessels become clogged. And if we clog these blood vessels, the heart muscle cannot get oxygen and sugar. These vessels only feed the heart. The heart doesn't have any other way to get nourishment. So we're very protective of these, and this is usually the biggest problem that we see with diabetes. Other concerns, this is large vessel disease. Other concerns are going to be smaller vessels, and we see those smaller vessels being damaged in the kidney, in the eyes, those vessels are equally as small, and in the lower extremities. We lose protective sensation. So these are small vessel problems. And in pre-diabetes, you already are starting to have these issues, but you don't feel it. And I often explain that if you cut your toe and you go into beach water that's very salty, you can feel it. But that's not true on the insides of your blood tubes. You don't have the same nerves and protective sensation. So diabetes is very, very silent. This is damaging you, but you don't feel it like you would on the outside of your body. So that's why we want to be concerned. Okay, it's like a thief in the night. It's going to take your health. So in as far as who is affected and who we look at in order to screen, if you are overweight, you are at very, very high risk. If you're physically inactive, we don't go out there and farm anymore and hoe and tote and milk the cow and gather it. We don't do that anymore. So we have to create ways to get movement into the body. Our bodies were made for movement. If you have a first-degree relative, meaning mother, father, brother, sister, you are at risk. You have the loaded gun. You have the genes in your makeup to lead to diabetes. History of heart disease. If you've had anything wrong with your heart before, you are at risk. High blood pressure linked to diabetes. Low protective cholesterol. We have some cholesterol in our bloodstream that collects the bad guys and takes them back to the liver so that they can get disposed of through our bowel. Polycystic ovary is a condition in women where the hormones are imbalanced, and those hormones cause a condition called insulin resistance, and we'll look at that in a moment. And then if you have had a baby and you had a large baby and you were diabetic before, during the pregnancy, you have a 50% chance, sometimes more, of developing diabetes in the next 5 to 10 years if you do not lose weight, if that baby weight stays with you or you regain weight. So these are things that we look at in order to screen. Now, every year, the American Diabetes the American Diabetes Association updates the guidelines, and this screening age, if you did not have these risk factors, was 45 years of age. But now they have lowered it to 35 because more and more people are getting it. We want to capture them sooner so that we can get on it and get these things addressed. One of the tests that you will hear about in the diabetes world is called the hemoglobin A1C test. This test is a test of the accumulation of blood sugar on your red corpuscles, your red blood cells. Those red blood cells are sticky, and sugar is sticky. Remember when we were little, we used to drink Kool-Aid and you spill it on the floor, and if you don't clean it good, you walk on it and it's sticky? That's what's happening here. And that red blood cell lasts for 120 days in the body. So we can go back a ways and see how much sugar has stuck to that red blood cell, and that is an indicator of whether or not you're within your range of control. So how do we diagnose? Well, there are several ways. One way is to look at what your blood sugar is in the morning, because you're getting sugar from two places. You eat food, that gives you sugar or carbohydrate for fuel in the body, and then the other place you get it is from your liver. Your brain has an obligate need for sugar or glucose specifically at all times. If you don't have sugar to the brain, you're going to get symptoms, nervousness, shakiness, you don't feel well, you know you have to eat. That can progress to seizures, coma, and death. So our insurance policy that you always have sugar to the brain is that the liver is constantly making new sugar. Okay, so we're getting it from two places. Did you have? Well, as the body is trying to correct a high insulin level, that insulin may not work very well, and all of a sudden it can break through and it starts working and it lowers the blood sugar. Okay. Yes, that can happen. That can happen. Okay. All right, that's called reactive hypoglycemia. Okay, so we look at that morning reading. Normal blood sugar in the fasting state is 70 to 99. Any person that we take that doesn't have diabetes, that's what they're going to be when they're hungry and ready to eat in the morning or before a meal. But if your body is not keeping pace with the amount of sugar that you're either taking in or making from your liver, that morning reading is going to be 100 to 125. When that morning reading steps up to 126, that is diabetes. Okay, that's one way that we can know. Another way that we can know is to load you up with some sugar, dextrose or glucose to be specific. Glucose and dextrose are the same sugar, but that's the form of sugar that all sugars have to turn into in order to be absorbed in the body. We can give you a couple of ounces of this really, really sweet sugar and then check your blood by vein. And at the 2-hour period, if you are between 140 and 199, you're not keeping pace with the insulin being produced or eaten. If it is 200 or more, that is diabetes. Then we can just take any person off the street and check their blood sugar, a random test. With prediabetes, they may be 140 to 199, depending on when they've eaten. And with diabetes, you're going to be 200 or more, but you will have symptoms of being thirsty a lot and having to go to the bathroom because your body's trying to throw away that extra sugar. And then the hemoglobin A1C test that I mentioned, normal is 4 to 5.6%. Not a lot sticks, but at 5.7 to 6.4, you're in the pre-diabetes range. When you get to a measure of 6.5 or more on 2 readings, you have diabetes. So these are different ways that we can check to see how your blood sugar is holding up over time. And as we get older, our age factors in to those risk factors. So here we'll look at some of the organs that are involved in blood sugar regulation or blood sugar control. First, we see the pancreas, and the pancreas is this little corn cob shaped boomerang or it's a corn cob texture, but a boomerang-shaped organ behind the stomach. It's a strange figure in there. This puts out the insulin when there is sugar in your body. And the insulin is going to cause the body tissues to absorb sugar. That insulin becomes either not enough or it doesn't work very well. The liver makes continuous sugar until you eat, and then it should stop. So the liver is our sugar bank. It's where we store sugar. It's where we make sugar to make sure that we always have some glucose or sugar on board. And then every time you eat, our guts produce hormones that remind the liver to stop making sugar and remind the pancreas to give insulin. So these have to stay in balance. But when you have diabetes, these hormones, the signaling isn't very good. It's like radar. You're resistant to hearing that signal. It's like running red lights, running caution lights. You don't get a good signal. The good news is we can give these as a medication now. So that's how it happens. So I mentioned on the previous slide that sometimes the insulin doesn't work very well. The problem is that when we have a high calorie storage on our body or in our blood vessels, the body is saying, hey guys, we don't need any more fuel in this body. Lock down, close the door. And the insulin being produced is not red. It can't register. It cannot open the door for absorption of your sugar. That's called insulin resistance. When you don't have insulin resistance, we say that you're insulin sensitive. You're sensitive to that signal. And in prediabetes and diabetes, you're no longer sensitive to it. What is going to happen is, in order to maintain the steady state, high insulin is going to be produced from the pancreas in order to get those numbers down. And what this gentleman was just asking about or noting is that sometimes that insulin can break through and all of a sudden it starts working and you get a low blood sugar. You feel like you're really, really hungry. Now the thing to note here with insulin resistance is that over time the pancreas is going to get very, very exhausted because it's producing all this insulin. And what we see here is a high insulin condition. What is happening is insulin is a growth hormone. It takes care of feeding you and storing things and making things. And so that growth hormone is going to be very high in the blood system, and it gets so high that it's going to seep through the blood vessels, and being a growth hormone, it's going to stimulate the color cells, and there will be staining or darkening of the skin. So this is a sign of high insulin levels. So this child would need to be screened for type 2 diabetes. And we see this in our community largely in young people. It can happen on the cheeks or wherever there's folds, a lot on the neck. And it kind of looks like a dirty neck, but it's not a dirty neck. This is high insulin that we see. And it will fade out over time as we get control and start working on things. But that's called acanthosis nigricans. It's a long word, doesn't matter, but you have seen this, I'm sure. So this condition is going to result in a high blood sugar level. And this is what is gradually building up over a period of 5 to 8 years before you actually make it to that 126 in the morning reading. 5 to 8 years this is happening. And in that 5 to 8 years, the damage from that little overage of sugar is happening. Okay. So I mentioned the symptoms. Thirst. You're tired because you're not getting all your calories. It's like you're not getting good gas in your body to fuel you. Weight loss. Unexplained weight loss I have that on there twice. Unexplained weight loss because the body is not being nourished. We have little battery packs in our cells in our body that need fuel, and if they're not being properly nourished, then you're gonna feel it. Frequent urination because the body's trying to balance things out by having you get rid of that sugar in your urine. So here's the Diabetes Prevention Program. This was a study done to see if diet and exercise really works to help people to not get diabetes. And what we learned from this study, people were counseled one-on-one, and they went through formal exercising for a period of about 16 weeks. And what we learned from that is that it did reduce the risk by 58% over 3 years. Now, if I told you that there was a 60% chance of winning the lotto over at that gas station over there, wouldn't you go over there? Yeah, we want to take this seriously. That's quite a bit. Now, the downside to this is the people lost the weight, but then did they maintain it? A lot of times they don't maintain that weight loss, and that's when we have to move on in our therapy and in our help to medications. So this was good. This is called evidence-based medicine. We took a large amount of people over a long period of time and put them through the program to see what would happen. So the DPP. Another arm of that study was medication. They looked at a medication called Metformin. The other name for it is glucophage. This is our first reach when we begin to treat diabetes. And more recently, there are some heart medications and other ways to treat diabetes that we might consider if you have high risk factors for cardiovascular disease. But metformin is still pretty much frontline, along with those other medications if they are indicated. It has a very, very low cost, about $4 in Texas. It is very effective in what it does. It does not cause weight gain like other diabetes medications can do, and it's well tolerated. We start low and go slow with metformin because part of how it works is it keeps sugar from being absorbed in the bowel. And when you get sugar and bacteria in there, it forms the gases, and so you can get a bellyache and cramps from it. So we start low and go slow with the dosing. A caution on metformin is that it is only eliminated out of the body through the kidneys. So we don't give it to people who have an ailing kidney. And there is another pharmaceutical that we use for dye studies. We don't give it if you're getting a dye study. So say you're going to have a CT exam. We're going to take a picture of you and give dye in your veins. We don't give metformin at the same time, so you have to go off of it. I happen to know the physician that brought metformin to the United States, Dr. Ralph DeFranzo, our very own world-renowned researcher in San Antonio, brought it to the United States in '95 with the help of the French pharmaceutical industries, and it has been very, very successful, very safe. And metformin actually has been used for hundreds of years for this purpose and for malaria, but it was repurposed, and we're getting a very good result from the metformin in general. Okay, and then the DPP, one of the main goals was weight loss. And so what the people were doing in this structured program of exercise is losing 7% of their body weight. Okay, so on 100 pounds, that would be 10 pounds, like that. And if you lose 7 to 10%, that's even better. Suppose I'm walking and I'm carrying a 20-pound bag of groceries, and someone comes along and says, "Here, let me help you with that." You feel good. Well, the body gets relief from as little weight loss as that. And we want weight loss to be slow and safe. So one of the ways that we can screen for overweight to know if you are at risk for a chronic disease is a screening measure called the body mass index. And what this is a height to weight score. It's a ratio. And so there are different categories of people that we look at: the underweight, The healthy weight would be a BMI of like 18 to 24, overweight 24 to 29, obese 30 and greater, and then morbid obesity. And what I have included in your handouts today is a little table where you can plot your own body mass index yourself. There are also online calculators if you're inclined to do it that way. But what you do is you find your height in inches over here on the left, okay? And then the scores are written across the top. And what you're going to do is you're going to find your height and your weight, so right here, and then you're going to follow that all the way up, and a BMI of 20 is in the normal range. Okay, so this is a kind of a fun way to see if you're at risk. And there are other measures, but this is a very simple one that's relied upon a lot because there's very little cost or effort to give us a lot of information. So part of the DPP was structured exercise, and what the people were doing in this study was they were exercising 150 minutes a week. And for you, that can divvy down to 30 minutes, maybe every other day. You can further divvy that down to 10 minutes after a meal. Better yet, 10 before, 10 after. It doesn't take that much. The thing is, if you're not in the habit of doing exercise, you're probably going to fall off. So what I counsel patients to do is start very slowly, baby steps, baby steps. I actually had a patient who had heart failure that was just vegetating at home and getting worse, and she was swollen. And I challenged her just to go outside in the morning. She did. And she said, I decided to put on my tennies. And I started going out every morning. And before you know it, she was going down to the mailbox and back to her house, and then she started going down the street and then back to her house, and then she started going around the block. She got better. Her heart failure really, really improved. So small, agreeable changes go a long way to establishing that habit. The numbers, the amount doesn't matter. It's the habit, like the heartbeat. I often tell patients that you wouldn't be in very good shape if your heart only beat once a week, would you? No, we got to have that steadiness, that stick-to-itiveness will get you there. Then a very simple thing that people can do is just get up every 30 minutes. Just get up. Use your muscle and bone. Challenge your system a little bit, because as we get older, we want to be concerned with what I call the 3 B's. Bone, brain, and blood. Blood for the immunity, our brain for our smarts. We want to be able to go and do and enjoy. And then bones. Our bones start to wear down and get porous as we get older. So jump up. Now that doesn't mean go to the refrigerator. Okay, it's just stand up. And the commercials can help you there. And then what's recommended is muscle strengthening exercises, because 2 places in the brain, in the body need a lot of sugar: the brain and the muscle. We have to power our bodies. So the stronger our muscles are, the better. So all movement is helpful, all movement. But if you can get a little bit more regular with it and a little bit more structured, that's going to go a long way. So we lower blood sugar, lower blood pressure, we burn calories, strengthen those muscles, and it helps the insulin work better, because then the body isn't saying, hey, we're overloaded here, no more, okay? All right, so healthy eating, we want to focus more on whole grain, because when flours have been worked and worked and worked and worked and they're white, they spike the blood sugar. There's no fiber to slow down the absorption of blood sugar. And I'm using sugar and carbohydrate in the same context here. Legumes are those little split peas. Those are really amazing little beans. They only cost $1.50 a pack. They're loaded with protein, vitamins, and minerals, and they have a very low sugar burning effect. The score on your lentil is 35, pasta 70, white bread, white sugar, a donut, 100. So combining these with some of the starchy foods that you like can be very helpful. Nuts, fruit, a minimum of refined and processed foods, because again, that protective layer that nature put in there protects you from quick release of sugar to spike your blood system. Veggies, veggies, veggies. What's wrong with veggies? People say veggies are rabbit food. Well, what's wrong with rabbits? They're so healthy, having all those babies. Now, we're not at that point in our life, but it's true that vegetables, the non-starchy type things that you would find in a salad, are very, very helpful because they're very low in carbohydrate. What we want to be careful with is our starchy foods like the grains, the breads, the cereals. Peas and corn are included in our starchy vegetables. So more non-starchy, lots of non-starchy. And then milk has milk sugar in it. So these are food groups that we do not want to leave out because we must be healthy first. Then on your food label, there is a way to know what these numbers are talking about, not the whole package. They're talking about a certain amount of food in the package. And so the first thing you look at is your serving size. I hope this doesn't. Okay, serving size. That's how much of the food in the container we're talking about. And then we want to go to the total carbohydrate count. Our basic measure is 15 grams. That's the weight of the sugar. And so 15 is considered a serving. So this says in 1.5 cups, it has a total carbohydrate count of 46 grams. That's 3 diabetic servings. Now the question is this a snack or is it a meal? A snack's worth is about 15 or 20. So that lets you judge the effect of this serving of food on your blood system. So in as far as dieting, we're getting away from that term anymore because what happens when you diet? You gain it all back. We can move your carbohydrate, protein, and fat proportions around and pull weight off the body, but it's usually not sustainable. You can't keep it up. So what we want are permanent changes. So our diet experts are now talking about food in terms of pattern. What is your usual thing that you do? When I'm talking to patients on the phone, what do you usually have for lunch? What do you usually have for supper? That's your meal pattern, and that's more important than adopting an artificial diet that, yeah, it's going to take the weight off, but it's going to come right back, and when it comes back, it's stubborn. It's really not going to go away. So overall, we want to look to lower calories because calories create weight, and what did we say? Weight tells the body, we don't need any more fuel. Go away, shut down, lock up, lock the door. And then lowering carbohydrate is very, very helpful. And high fiber. We want fiber to bind our food so that it moves slowly through the bowel to give us time to come up with proper insulin to absorb that nutrition. And then we want nutrient-dense foods. The American Diabetes Association now is saying quality over quantity. We want to get every single micronutrient, vitamin, mineral, and fiber we can from our food. So lower those calories. This is the USDA Healthy Plate. This is a very sensible way of eating, and what it looks like in reality is going to be lots of non-starchy salad-type vegetables on a 9-inch plate, and then a quarter of the plate would be your animal meat protein, and then a quarter of the plate would be your starch. You can always have a milk or milk product on this method and a small serving of fruit. Now we have the cuties and the clementines and those small fruits. We want that fruit, we want the fiber, we want the vitamins and minerals and potassium, but we don't want to overload ourselves with too much glucose or fructose. So, some suggested evidence-based diets are going to be the Mediterranean. This is the most studied meal pattern that we know. It's a poor man's diet. There's essentially no red meat, no sugar. They don't have drive-thrus. Mama's in the kitchen cooking. And so this is what's best for our bodies. Lower carbohydrate meal plans are very, very helpful, but not too low. We want to cut back, not cut out. And then vegetarian diets are very healthy. And then the dietary approaches to stop hypertension is an evidence-based diet that lowers blood pressure. And they're all very, very similar with lots of vegetables, non-starchy vegetables. So we want to keep up those screenings, keep the blood pressure less than 130/80. Your blood pressure targets now, what you're going for is individualized depending on your individual risk for cardiovascular disease. So we're looking at that very, very closely to establish where you should be. And then keep your salt less than 2,300 milligrams per day. The average American gets 3 or 4 grams. And again, grams is the weight of that salt. And then total cholesterol less than 200 milligrams on your total count of the cholesterol, because sugars turn into fats, and fats have those bad proteins that can hurt our coronary artery. If you drink alcohol, there are limits for more than one reason. Alcohol generally has a blood glucose lowering effect. Initially, it raises you because it has sugar, but the overall effect is going to be to lower the blood sugar. So this is of particular concern if you have type 1 diabetes, where there is no insulin in the body to absorb sugar, and then alcohol ties up your liver's ability to create sugar. So if you don't have any sugar and you don't have any insulin, we find you on the floor. And it can be very serious and life-threatening. But with type 2, less so. If you smoke, we need a conversation with the doctor about your readiness to quit. You may not be ready, but we still, as your healthcare providers, have duty to you to make that decision in an informed way. So we're willing to help with that. Okay, there are DPP programs around the country, and in the last few years, Medicare has gotten in on the DPP, and so Medicare helps to sponsor these programs. And I looked at this locator online, and there is a St. Paul's church in the area. They are a DPP program. I know Schertz also has a DPP program. This is structured exercise, probably has some group meetings in it to help people to lose weight in a structured way. And as in the AA tradition, I love this line, it works if you work it. Okay, you can know about it, but you have to put it to work. Okay, so our take-home points today. We want to eat well. We must eat well to have health. And I have had occasion, unfortunately, to say to members, yeah, I know, there comes a day to pay the piper, okay, because these diseases are silent. We want to move more. All movement is meaningful. All movement is helpful. So in the morning, we want to hit that floor and get going and live the day as vigorously as we can, and then lose weight, okay, and we must keep it off. So that fuel that we're taking, then we got to go out and spend it in terms of activity. And we may have to create those ways to get that activity in there. So we don't have cows and chickens in the backyard anymore, but there are ways to do it. And you can do it. Okay? All right. Questions? Works if you work it.